Greetings, I'm Yvonne Stapp for Science for the Public, and I welcome you to Contemporary Science Issues and Innovations. Today, what's wrong with American healthcare? Although the U.S. is one of the wealthiest nations in the world, we rank well below all other economically advanced nations in providing healthcare. In other modern nations, healthcare is a birthright and universal healthcare is the norm. Here to explain our problem is Melissa Garrido of the Boston University School of Public Health, where Dr. Garrido is a health economist and research associate professor in the Department of Health, Law, Policy, and Management. We are very pleased to welcome Dr. Melissa Garrido. Thank you so much for joining us. And Dr. Garrido, in your opinion, what is the best health system in the world today?
Well, thank you first for having me today. I would say that to think about what the best healthcare system is, we need to think about what do we even mean by a healthcare system. So this is a group of purchasers, so business and government. It's the payers, it's the providers, and it's the people who are receiving the healthcare itself. If you look at rankings, so the Commonwealth Fund releases ratings every year or every few years about which high-income countries are consistently on top of healthcare provision. The Netherlands and Australia are frequently on top. And by the way, the U.S. has ranked lowest in these ratings over about the past 20 years. So the Netherlands, excuse me for a second. So these rankings are based on things like access to healthcare, types of healthcare provided, administrative burden, equity, healthcare outcomes. Access to healthcare includes things like, can people afford healthcare? Can they get an appointment within a reasonable time? Types of care are things like preventive care offered. Do people coordinate with one another, or are you just going to a bunch of different doctors without without anybody talking to each other? And is there equity among both high and low income individuals in a country? So Australia and Netherlands frequently rank at the top of these lists. Australia has universal coverage. It covers public hospital care and portions of both outpatient care and medications. And everybody in the country has this. It's funded through general taxes and income taxes.
And this doesn't cost a fortune, right? It doesn't cost a fortune for people in these countries. Right. That's a major thing, right? So you've given us a description of this, and it covers everything, apparently. These systems cover everything. That includes dental. It's not, and you don't have copay and everything like that, right?
It depends on the system, how it's structured. So, for example, in Australia, they have this universal coverage, but then there is private insurance that can be added on. And people are strongly encouraged to purchase that. In the Netherlands, everybody's required to purchase private insurance. And then if you want coverage for things like dental care and vision, that requires some additional purchase.
Okay. And is it affordable in these countries?
Yes, especially compared to the U.S. So in the Netherlands, I believe the average cost is less than $1,700 a year for insurance coverage.
That'd be a trip to the dentist here, practically. But I want to ask you about that, or just follow on about that a little bit. Apparently, I know these figures differ perhaps with different studies, but almost 10% of the American population does not have health care. So that means that if you are going to have a baby, there's a question of whether you can afford to have a baby. Is that correct? And all the other things included, which all of that came out very clearly in the COVID epidemic, where people could not afford to get medical care. Is that correct?
Yes.
And that, go ahead.
Sorry. That is correct. 1 in 10 Americans do not have health insurance.
Yes, and that's very significant compared to these other countries. Is that correct?
Yes. The U.S. is the only high-income country that does not have universal coverage.
Okay, and why? I guess is the big question. This creates a huge inadequacy in healthcare. It's just inadequate. So you have fabulous medical schools, fabulous laboratories, fabulous physicians, everything is there except you can't afford it. But so why are we so inadequate? What's the mentality there?
That's a great question. We have this lack of insurance coverage. We have high costs, and we're also really inefficient relative to other healthcare systems. So the U.S. spends a lot on healthcare. It's almost 20% of our GDP, and
Wow.
that's mostly covered by the government and households. Um, we could allocate our resources in a better way. We spend quite a bit of money on administration, so things like billing and coding. Medications are really expensive. In Not using best practices for care delivery, so things like using best practices for preventive care. We do a lot of overtreatment, just providing low value tests or medications that don't have any actual
Yes.
benefit. And there's also fraud in the system, both the costs of people who are actually submitting fraudulent claims, but then the costs that are included in trying to investigate and prevent that fraudulent activity.
I see. And so we're going to get an excuse here. Well, if it's better if it's privatized, and we hear this theme constantly, and there's a huge movement to privatize practically everything in this country, it seems like these days. But this has been a very strong issue as far as medical care has gone on for ages and ages, and I'm not sure that the public is aware that everybody else has medical care, but we don't. And then there's this argument that privatization is better. What has privatization done to us in fact? Does it offer anything?
Well, I think it does offer something, and I could talk a little bit about why we are here today. And I will note that countries like Netherlands, they do use private insurance.
Yeah,
So
right.
there's different ways to try to use even private insurance to get universal coverage. Um, Privatization in the U.S., it really comes from a mixture of kind of American values and norms about wanting to be independent, the appropriate role of government. There's lobbying,
Yes.
and then some of it, actually quite a bit of it, is consequences of wage control that occurred during World War II. So this has been a struggle since about 1912. That was the first push for universal health insurance, and the American Medical Association wanted universal health coverage at first. Um, some of the unions didn't like it so much, and what we had World War I, and that kind of turned popular opinion uh, against having government really involved in our personal lives. But health insurance was considered again for inclusion you know in national coverage in the Social Security bills. This is 1935, um, but because people were starting to feel like that was a little bit too much government control. With the Great Depression, everybody was worried more about the economic impacts. So to get Social Security passed, health insurance was kind of dropped to the side. So you have this kind of back and forth for national legislation, but at the same time, some other groups took matters into their hands, and this is where the privatization kind of started to occur. You had precursors to Blue Cross covering hospital expenses for teachers. You had precursors to the Blue Shield programs paying for physician expenses, and this is in the 20s and 30s. And then we get to World War II, and there's wage freezes, but fringe benefits, including health insurance, weren't subject to those same wage freezes. So there was a way to try to compensate employees more by giving them better health benefits. So this privatization kind of occurred naturally to try to meet the need and the desire for having some health insurance coverage. And then commercial companies saw that this was kind of a lucrative market and jumped in and kind of took off from there.
And that has continued, that there's a lot of profit in this, I think. Is that correct? I'm not sure. I think physicians and other health professionals make perfectly decent livings in other countries where they have universal health care. But here you can really get rich, if you're a surgeon or a psychiatrist. Is that part of the motivation on the part of, say, AMA, the antagonism towards universal health care?
Yeah, I think there's definitely lobbying by some
Yes.
medical groups that has helped kind of prevent progression on universal coverage. And there's, in addition to that, though, I think there's, until maybe recently, there's been kind of a lack of grassroots support. So programs like Medicare and Medicaid passed finally in the 60s because they had really wide-ranging popular support, providing additional benefits to a group of retirees that was politically popular. And we haven't seen the same kind of interest from the public since then.
This is coming up now. The public certainly wants to have the universal coverage at this point, but this is not happening. There's been a real struggle to get it. I'll come back to that in a minute, too. Dr. Garrido, what populations or what sector of the population in the United States is most vulnerable because of this situation, that they don't have health care? What sectors?
Yeah, so I think I think it's important to distinguish between healthcare and health insurance. So I think the group that is most vulnerable is the uninsured. So we talked about 1 in 10 Americans are currently uninsured. There is also a substantial portion of individuals who are underinsured. So they
Yes.
have coverage, but they might have a high deductible health plan.
Right.
So something really terrible needs to happen before they decide to go seek care in some cases. And having a lack of insurance is associated with not getting needed health care. So
Yes.
individuals might skip preventive care. They might not get screening tests, so different illnesses might not be caught in time. Or they might delay some needed care, might not take enough of the medications. So all around, they're either getting less or delayed or even foregoing care.
I see. Would you add also, by any chance, that these groups that are subjected, because they are poor, they are subjected to a lot of environmental toxins? There are whole areas like Cancer Alley in the South and so on, where people have very high rates of cancer and other diseases because of environmental toxins. They have no control over this, and they also do not have adequate health care. Is this a problem in your eyes? Do you see this as in abundance here?
Yeah, I think that's certainly an issue. I think a history of structural racism has led certain groups of individuals to be living in areas where there are fewer environmental controls, where toxins have been dumped, and combine that with lower access to insurance and to health care, that exacerbates the health impacts from those environmental stressors.
Right. Now, we have Medicare and Medicaid. Could you give us a brief idea? There's a real push, has been for quite a while now, certainly from the progressive population, for Medicare for all, but it's not there for all at this time. Do you see that as a solution yourself to our problems, and what are the differences there?
Sure. So let me start with the differences.
Yeah.
So Medicare is a national program. It is targeted to older adults. So the primary people who are eligible are 65 and older. And it also applies to people who have some disabilities, end-stage renal disease, and ALS. It covers hospital expenses, physician expenses, and there are also medication plans now that are covered. What it does not cover is long-term stays in nursing homes. A lot of people have a misconception about that. Medicaid, on the other hand, that this is a national program, but it is administered by the states. There's a lot of state-by-state variation in who is providing which services. Eligibility here focuses on lower income individuals. So at least in states that have expanded Medicaid eligibility since the Affordable Care Act, this includes up to 138% of the federal poverty level as kind of a baseline eligibility criteria. As far as a Medicare for All proposal, I think Medicare for All proposals, there are that encompasses kind of a wide range of different policy proposals. Mm-hmm. But the general goal of all of these is to improve or simplify healthcare financing, reduce costs to individuals and families, which I'm totally on board with all of those goals. I think the best way to actually achieve this is unclear. There's some assumptions in many of these proposals that if we try to centralize coverage, we're going to have a lot fewer, lower, rather, costs of administrative health care coverage.
So,
I don't know that that's necessarily the case. So, a Medicare for All program or some kind of universal coverage program, it's going to necessarily need to expand to meet previously unmet demand for healthcare. So then there might be administrative costs associated with working with these populations that have previously not been able to access care, or costs that are currently associated with billing and coding and some of those technicalities might be replaced by costs with coordinating care across different providers, other activities that are currently underfunded. Not to say that there's no path forward. I just think that an incremental approach is probably better than anything that tries to replace the current system altogether.
Okay, can I follow up on that? What do you mean by incremental? And that leads up to the question, what's, in your view, what is the solution? What's the best healthcare program? And I'd like to know about this incremental part.
Yeah, so I think starting small. So any type of health reform, or most types of health reform, have to move a little bit slowly just for political feasibility. So things like the Affordable Care Act was never meant to be the overall solution to health reform. Right. It was meant as something as a great start, but to keep building upon it. So things, some of this has just been implemented or passed in the past year. So we have the Inflation Reduction Act now allows Medicare to negotiate for prices of pharmaceutical drugs. So, adding more of these meaningful price controls to help reduce out-of-control spending on medications and kind of combat some of the monopolies that are driving prescription drug costs. Mm-hmm. That is a feasible and actionable step towards reducing healthcare costs. I think long-term, it would be great to not have health insurance tied to employment. Maybe there's a way to model the Netherlands system where everybody has to purchase some type of care, but maybe it's not tied to a job, so that mm-hmm. folks are able to move on to a new job without worrying about losing coverage for any kind of chronic conditions they may have. I also think there should be a greater focus on primary care and preventive care. Mm-hmm. Right now we have shortages in the workforce for primary care, geriatrics, mental health care, nursing, mm-hmm. Direct care workers who provide care to individuals in their homes. All of those areas focus on catching medical conditions early on or working with individuals to prevent the development of chronic conditions. And they focus more on the whole person and yes. managing symptoms and not trying to treat a condition once it gets out of control and is incredibly specialized.
Right. You bring up a very important point, and I'd like to emphasize it there that you need much more emphasis on a more general approach to health. Yeah, not just going to the doctor when something goes wrong, not just medicating something. So that, for example, we have an epidemic, I believe, of diabetes 2. Is that correct in this country? A lot of that is due to diet in this country, I think. So from the public health point of view, I guess you're thinking, well, go for the problem, solve that problem there that creates the medical condition, I guess. Do you have other examples of that, of where you need a more general public health approach, fix the environment in which people are getting ill, like the diet?
I think diet is a really good example of that, just because diabetes does affect so many individuals. And it's a case where, yes, there's diet, there's access to nutritious food is an issue. But we know that we have a lot of people in our healthcare system that have diabetes, and yet until the Inflation Reduction Act, we had no price controls for insulin. Now we have them for
Yes,
Medicare, but we don't have it for commercial insurance.
yes.
So a lot of there are a lot of kind of environmental and social factors that might be beyond the purview of a healthcare system, but there are things we could do within traditional healthcare and insurance coverage to improve the care that we can provide for those conditions.
I see. One other thing there is you just mentioned the pharmaceuticals, and that is spectacularly different, I think, from other countries. That the drugs are so expensive, apparently, and that came up with the COVID epidemic as well. What is the reason for that? Why are our medications so much more expensive than they are in other nations?
Yeah, there are a few reasons. Monopoly power
Yeah,
is one of them, or near monopoly power
yeah,
anyway. If you don't have a lot of competition to create similar drugs, there aren't many levers to reduce prices. Um, and along with that, there are kind of schemes that companies use to delay the release of generic drugs that would be appropriate competitors, or to tweak a drug just slightly so that it qualifies for a new patent and thus a higher price than it would otherwise. Um, the the overall lack of bargaining ability between purchasers of drugs in the U.S. and the pharmaceutical companies is also an issue. I'm hoping now with the Inflation Reduction Act that
yes.
helps address some of these issues anyway. Um, and um, I was going to say one other thing. Now it has slipped my mind.
Oh, well, that's okay. I was just trying to get at why our costs for medications are just at a different scale altogether than they are the same drug in another country with more universal health care and more accessible and everything else. But so you basically answered that question. In your view, then, what would be the optimal system? You said it needs to be incrementally approached, but what would it cover? And would it be federalized, or would you say, oh no, leave it up to the states, as I think that still exists here, decentralized?
Yeah, I think just because of the history of healthcare in the U.S. so far, I think moving completely to a federalized system will be incredibly difficult. Maybe it'll be possible eventually, but I think probably a staggered approach. I think Medicaid is actually a better model than Medicare for trying to increase coverage, because it is a federal program. It's administered by the states. There's room for flexibility. Populations differ across states. There's room for experimentation. States can apply for waivers within the Medicaid program to provide care in different models. And that's given rise to a lot of innovative home and community-based service models, especially for older adults or for people with disabilities. So I think expanding that kind of system might be the most feasible approach.
I see. And another thing here is that, again, going back to the COVID epidemic, we had, for a while there, we led the world in mortalities. It was scandalous. In your view, what causes this very disproportionate? I understand our mortality rate is high anyway in this country compared to other developed nations, other wealthy nations, I should say. What is behind that you get this disproportionate mortality rate?
Yeah, and that's a great point. Yeah, we are ahead in mortality, unfortunately, where we are the worst, or one of the worst in maternal mortality and infant
Yes,
mortality.
that's another important one.
It's incredible. A lot of this is, in my opinion, is inefficient allocation of resources. As you mentioned, we have great training available in the U.S. We have a lot of resources, but they don't get to the people who need them. So I think that lack of comprehensive coverage is really important. Among pregnant women, a lot of people qualify for health insurance because they are pregnant. So that's might be their first time that they are entering into a environment where they have insurance coverage to seek preventive care. If care drops off after the child is born, after the coverage period, then that reduces the ability to be tracking people for really common complications, things like hypertension, depression. And so a lot of the adverse effects of our health system come down to that lack of insurance coverage.
Yes, I see. And I'd like to also add, I think that in other nations, you mentioned the mortality rate with pregnancy. In other nations, there is parental leave. It is a right, so that you support the family. In fact, the public supports the family. We don't have that. Is that correct? And
Correct.
should we? And would that help health of the mother and of children? And so just health of the families.
I don't see why it wouldn't help. I
Yeah,
guess.
right. But it's just peculiar that we are alone in not having parental leave at a time when the mothers need to kind of heal and bond and all of that, but it also is support for the family. And I thought that had come out also, that children were denied or were not able to have health care during this crisis and other conditions like this too, widespread health conditions. Is that correct, that our children are vulnerable?
This is an area I honestly know a little bit less about, so I don't want to pontificate
All right,
about leave.
right. I understood from somewhere that the children are until the IRA, the recent act, that children now maybe have more access to health care, but that was a deficiency also. Okay. Last question, Dr. Garrido, what can the public do to advance the cause for public health and public insurance?
Yeah, I think it's just important to understand the role of public health. So there's public health and health insurance. I've been talking a lot about health insurance, but public health broadly we've seen this during the COVID pandemic. We're seeing the limitations yet again with monkeypox. It's right now public health is underfunded. So that means we don't have enough people to effectively communicate to the public. There's rather slow reaction times in terms of setting up labs or getting vaccines rolled out. But a lot of that is because of a lack of funding. And I think something that there needs to be greater recognition of is that we can't all rely on individual responsibility, especially in a public health crisis. We need supports. we should think of public health more like other public goods, like fire departments. Imagine if everybody was
Yeah,
asked
right.
to, take care of any fires that occur in their own homes. That's essentially what we're doing with public health right now,
Yes.
and we need more support for that.
Yes. Thank you, incidentally, for bringing up the need for more better financing of public health, like public health schools, training people in these fields. They do a very important job, and there's plenty of money. It just gets misallocated, maybe, in this country. But appreciate the work, of course, of your organization. The Boston School of Public Health does a fabulous job of training people, but also presenting events for the public, for their information, very easily accessible. We'll make sure we put a link to that on there, but you're a very active public health school. Dr. Garrido, thank you very much for all this wonderful information and for sharing your time and expertise.
Thank you for having me.
Okay, bye-bye.